So welcome everyone. We are very happy you're all here to be with us during this dedicated symposium to tattooing. I'm chairing this session. I'm here with my colleague Professor Rodrigo Jover from Alicante, from Spain. My name is Evelien Dekker from the Amsterdam University Medical Centers. We are expecting soon Professor Bhandari as well. I know he's around and he will be in soon as well. So the concept of today, this symposium, is to discuss with each other practicing tattooing. So what are the indications and how should we do it? So it's going to be a very practical symposium, open for discussion. The two lecturers will have a nice presentation, but let's discuss with one each other to try to deliver optimal practice. One important remark to make, this whole symposium will be videoed as well, so, and it will be in the ESGE learning platform. So if you are interested in looking back at it, or maybe want to suggest your colleagues, you can look at that at the ESGE platform. So I think that's a very nice supportive way of optimizing our tattoo practice. So then, as a first speaker, I would like to invite Rodrigo, please, for your talk. And you are going to discuss with us when and where to tattoo. Please.
Okay. Thank you. So, my disclosures. Endoscopist tattooing is the most reliable method of polyp or tumor localization in the colon. Endoscopic tattooing is indicated to facilitate localization of a luminal abnormality at the time of surgery or repeat endoscopic examination. But there are no clear rules for endoscopic tattooing, this homemade-based practice. There is very small evidence-based practice. There is only some advice from guidelines. So in that case, where so small evidence is running, there is a role for consensus recommendations, and this is the aim. One of our aims is to set a Delphi consensus for establishing the best way to do tattooing. Tattooing is also used in other places in the GI tract, in the esophagus, in the stomach, in large bowel, or in the under the EUS for localization of pancreatic lesions. The main questions when we talk about tattooing are when tattooing shouldn't be used, because there is a regular practice for that decision. When should tattooing be used? In case of colorectal cancer, in case of suspected colorectal cancer, in benign lesions that are referred for treatment elsewhere, or where there is a need of future surveillance, and how should be the tattoos placed. That's the topic of Pradeep's talk: technique, location, number of tattoos, and volume that should be injected. This is a meta-analysis, a systematic review of meta-analysis that was published 2 years ago about the evidences we have with tattooing. The majority of studies we have, almost all the studies are observational studies, so there is, as I said, limited evidences. But the one thing we know from this meta-analysis is that without tattooing, the bad localization of colorectal cancer at surgery, the lack of localization of colorectal cancer at surgery is 15.4%, and we improve that numbers with tattooing to 9.5%. So even using tattooing, we see that the other way around, even using tattooing, we can miss almost 10% of cancer. So there is role for improvement in that topic that we want to discuss here. The main need for localization of colorectal cancer came with the laparoscopic surgery of colorectal cancer, or with the surgery of polyps. There is, as I said, up to 15% of incorrect localization of colorectal cancer at surgery that provokes the removal of the wrong segment of the colon. That's an experience that we all have experienced that is quite awful. and that provokes also changes in the surgical plan in 4 to 11% of cases. Another indication for this need of localization is intraluminal, is the identification of polyps for second look or endoscopic resection, and maybe things could be different in this other scenario. And the third main indication for localization of something we have done in an endoscopy is the identification of polypectomy site because of the suspicion of malignancy, or because piecemeal resection that we have to review in some months, or in large polyps, or we have to schedule which should be the cutoff for doing this tattooing. Localization errors, there are several observational studies that indicate that can happen in several points of the colon. The more common are transverse colon or descending colon. And under this condition, under this situation, how are the GI doctors performing tattooing? We have also not too much data about that. These are results of a Canadian survey that we can see how in some indications there is agreement of the use of tattooing, lesions that cannot be removed with colonoscopy, or polyps with high-risk features that we should define that may require resection. In other scenarios, that's not so uniform, the use of tattooing, polyp with features that may require follow-up colonoscopy, or lesions highly suspicious for malignancy. Also, in surgery, when patients are sent to surgery because of colorectal cancer, there is high agreement of tattooing, and there is also disagreement when we talk about different localizations in the colon. For example, in the rectum, there is a 20% of doctors that do tattooing, and 80% that don't in that survey, and also we should have an agreement about what to do with tattooing based in the highest evidence possible. Because one can say, let's tattoo everything, and I will be able to localize everything, but that's not that way, because tattooing also, as everything in medicine, has some problems. It provokes a longer procedure, most of the times after an already long procedure. We can, especially in colorectal cancer screening programs where find multiplicity of polyps is frequent, we can provoke multiplicity of tattoos if our cutoff for tattooing is too low, and we can see the colon like a Dalmatian dog. We can also provoke tattooing spilling. This is one of the risks because of transmural injection. That is particularly relevant in the mesorectum, in rectal tumors, when tattooing can invade all the mesorectum, provoking problems for surgical resection. This transmural injection also can provoke diffuse staining of the peritoneum, even sterile peritonitis or abscesses. We will see some examples. We can also provoke needle metastasis with tattooing, and another secondary effect is the submucosal fibrosis. When we tattoo over a polyp we have to remove later on, we can provoke submucosal fibrosis that can complicate the future resection, so we shouldn't tattoo over or on top of the lesion. That can provoke perforation of difficulties for EMR. This is the rate also in observational studies, the tattoo spill rate. It rates from 4 to 14% of cases. It is due initially to a bad technique that for sure Pradeep will teach us how to do that. This is needle metastasis. This is an example. That guy put the tattoo on the tumor and also besides the tumor. And we can see here the tattooing in the submucosa and this nest of malignant cells that have been transported by through the needle of the tattooing. We can see here the tattooing and these malignant cells that are here instead of here. We can see also liver abscesses because of a spilling of the tattooing with intact colon. And we can also see some examples of fibrosis due to the tattooing in the lesion. We can see here this tattooing in the lesion, here, not so good. And when these doctors remove the lesion, they provoke a perforation due to the fibrosis the tattooing provoked previously. We don't have too much recommendations. The only guideline that set specific recommendation is the ESGE guidelines, and these recommendations are only these four. ESGE recommends that lesions that may need to be located at the future endoscopic or surgical procedure should be tattooed, recommends the use of sterile carbon particle suspension, recommends the formation of a saline bleb in the submucosal prior to the tattoo injection, and recommends to place the tattoos at least 3 centimeters distal to the lesion with 2 or 3 separate injections with a local protocol for doing tattooing and with the details of the tattoo injection being clearly reported and photo documented in the endoscopy report. So, the first thing in Delphi we are going to launch, the first thing we want to ask is when tattooing shouldn't be used. There are some experts that don't recommend to do tattooing in the rectum, also don't recommend to do tattooing in the cecum because the cecum is itself a hallmark. It doesn't need to be remarked. But there is also some different opinion that's good to have that with consensus in this procedure we want to start. ESGE recommends that lesions that may need to be located at future endoscopic or surgical procedures should be tattooed. That could be colorectal cancer, could be polyps with suspected invasive colorectal cancer, polyps referred elsewhere for resection, or polyps needing surveillance. But the question is that always necessary? Is that in all the cases necessary? That's another question we are going to ask for the Delphi. For example, in case of colorectal cancer, there are some studies that say that if the colorectal cancer is big enough or is stenotic or is occupying more than 50% of colonic lumen, maybe it's not necessary. We want to get that consensus. In another scenario, in case of suspicion of invasive carcinoma, there are also different options to do always or to do based on the size of the lesion or to do based on the intention we have for future procedures. In case of benign lesion referred for treatment, also would depend or could depend on several conditions that we want to ask to the experts, and also in scenarios when tattooing is used based on the need of future surveillance. It depends on the size, it depends on other conditions that we want to find it out. Another question is where to place the tattoo. ESGE recommends at least 3 centimeters in the anal side of the lesion with 2 or 3 separate injections. I don't know if it is common practice to do so much injection or to do something just one. Distance, how many injections, which is the protocol for making this injection, and how should be this documentation. We already know, as I explained before, that fibrosis secondary to tattooing difficulties future procedures, so we shouldn't use tattoo. We shouldn't tattoo on the polyp we are going to reset later on because of this fibrosis that we can see here, the tattooing and the proliferation of fibroblasts that these substances provoke. And we also want to ask to the experts in the Delphi where should we locate the tattoos, as well as the number of tattoos. It is possible that the number of tattoos also depend on the intention we have. Probably we will need different number of tattoos if we are going to send the patient for surgery that if we are going to do an endoluminal procedure. This is some of the evidences that also come from this meta-analysis. These authors saw that there is less errors when circumferential tattooing is used in laparoscopic surgery, less errors of localization, only 3% when circumferential tattooing is used. And another question that we'll explain Pradeep before is the volume of tattooing. It is also not clear, it's only expert opinion. and other questions like details, how to report in the endoscopy report the characteristics of a wet tattooing, or if we should photo document that, or how to build an institutional protocol for developing rules or local rules for tattooing. The same with the technique of tattooing, the use of saline bleb in the submucosal. That also in this meta-analysis we see how errors of localization are lower if we use this technique of placing the tattoo in the colon. So, in conclusion, tattooing is the best method of localization of lesions in the colon, but some questions remain: when and when not, how, and some details about the technique. It is difficult to demonstrate evidences because it is difficult to launch, for example, randomized controlled trial that compares different scenarios in tattooing. It is almost undoable. So there is a role for expert recommendation that we want to develop under this Delphi process. Thank you very much.
Thank you very much, Rodrigo. So the idea is that we first listen to the second talk of Professor Bhandari. Please come sit here on this side. And then we will have discussions with you. I think that's better.
Excellent. So I'll keep it very brief, and how not to place the tattoo. Well, not those tattoos. We're not going to talk about that now. But I think Rodrigo has already talked about the consequences of poor tattooing, so I don't need to go there. But this is one LST non-granular type being referred to me. They placed the tattoo. In the report it says 7 centimeters away. Look at that. Potentially that was the site. The tattoo is migrated all the way up to the lesion. It's almost made this non-granular LST not resectable endoscopically, because non-granular LSTs themselves by nature have submucosal fibrosis. They have stromal reaction they produce. Now you put a tattoo as well next to it, you produce more fibrosis. It's a very difficult ESD to perform in transverse colon, and everything's very complicated now. So might as well send this patient for surgery. That would be the best way to resect. So that's the consequence of not thinking properly before placing a tattoo. So be aware of migration. So what do we do in terms of techniques? There is direct. You can inject the tattoo directly. You can have saline bleb followed by a tattoo at the same time. Or you can have saline bleb first. Then you empty your catheter out of the saline. Just prime it with tattoo. And then inject 1 ml of tattoo. And I'll talk through these 3 different ways of doing and the pros and cons of it. If you are somebody who has very good injection skills, done thousands of EMR, are very confident, in those hands, this direct injection could work. You can see here a needle placed straight in, injection starts, you straight in the submucosal space, and a very nice, very small, discrete little tattoo being created. Highly unlikely for this tattoo to migrate. This is very nicely created. It's a great idea to do like that. That's how most of the tattooing was done in the past. So there are advantages of it being very precise and localized. It's very dark because you haven't used any other solution to dilutes. So very difficult to miss a tattoo like that from inside or outside. And there's no migration. However, this is a very big however. A majority of us are not perfect in injection. When we push the needle in, we don't know exactly where we are. Have we gone through the muscle? We are too superficial, or we are in the submucosal plane. So we might end up injecting through the wall and cause peritoneal soiling. And that's a disaster if surgeons have to do a laparoscopic surgery afterward. So that is a big, big disadvantage of this technique. You inject, this is another safest way of doing is saline. There's the saline bleb being created. We know it's come up. Immediately we swap the syringe from saline to tattoo, and now the tattoo is being pushed into the saline bleb without taking the needle out. You can see the black tattoo coming through, filling up the saline bleb with a tattoo. So now there's a nice big tattoo, half filled with saline, half filled with tattoo. So it's quite a nice big tattoo. That is a safe way and overcomes the problem of the previous technique. So the advantage is there is no risk of peritoneal soiling. So this guarantees that you're not going to go through the wall and cause soiling. Disadvantage is you might end up putting too much fluid. Remember, to inject and create a bleb, you need about 1 or 2 ml of saline to create that. And then you have another 2 to 3 ml of saline already in your catheter. So when you start injecting the tattoo, you already pumped in 4 to 5 ml of saline. And then, because you don't know when the tattoo is going to come out, and when it has come out, you'll inject another 2, 3 ml of tattoo, end up about 10 ml of fluid in that bleb. And that's the reason why these migrate. I trust my colleagues who refer patients that they have put a tattoo 7, 8 centimeter away, but because they put such massive volume, that's why it migrates. So that's the disadvantage of it. So that's why you need to think about it and be very, very careful. And also, other disadvantage, it could dilute. But these days, the tattoo, like this current tattoo, is very, very dark black. So maybe dilution might not be a problem, but otherwise you could dilute it. So what is another way of doing? This is the other way of doing, which I prefer, is you inject saline, you take your catheter out, the needle out of this bleb, and empty your saline out now. You prime it now with the tattoo. So you see all the saline coming out in the lumen. As soon as the first drop of tattoo comes out, you go back into your raised bleb, and then you inject 1 ml of tattoo. So 1 ml of saline, empty the catheter, put the needle back into the bleb, 1 ml of tattoo, and gives you very precise tattoo. Oops, sorry. So this should work. Okay, so there we go. So you push your needle into the submucosa. There, you got a bleb. That is, you don't need any more. That's it. You take your needle out, emptied it, there's only tattoo there now, and you start your tattoo injection, another 1 ml of tattoo in there, and then you'll have a very discrete, localized tattoo with no risk of it leakage. There you can see, so you got a nice little tattoo, another tattoo on the opposite wall, and then you are safe. There's no migration, and there's no peritoneal soiling with this tattoo. So that's another very good way of doing it. And finally, so that is the advantage. It's precise, it's safe, no migration, darkness is preserved because you're not putting in 5 ml of saline to dilute it. Disadvantage is it is a bit messy. You inject, you take it out, you empty, you go back. So it is a bit of a messy affair. So you have to think about that. I'm not going to show you this video, but maybe if we come to the technique, and there we go, okay. So if I run it from here, so what we're doing now is the nurse is shaking the tattoo, getting it ready. I'm not sure if the shaking is required or not, but that's become a habit. Is it required, shaking? Oh, good thing, okay. So that's a good thing. That's the tattoo we are using in this case. Oops, sorry. Goodness me. ESGE doesn't allow any commercial thing coming up. So ESGE is blocking that. So I'm sorry, there's no volume here. So what we're saying is that we're going to start the injection. You'll see in a minute. The needle will come out. So I'll finish that in 2 minutes, Evelien. We'll inject the saline into the wall, raise a bleb, and as I was talking earlier, you'll see how you empty your catheter in the lumen without taking it out and priming it outside. There, good. So put your catheter in. God, what happened there? We'll go back to the endoscopy screen in a minute. Fast forward it a bit more. Okay. I'm talking too much. That's what's happening.
The patient as well.
Yeah.
I could see.
There you go. The
good.
bleb being created, saline gone in, nice bleb, okay? And the tattoo, both at the same time, but just don't push too much, okay? I'll stop. I don't think we need to go through. I think it's better to have more discussion rather than talk more about this. So thank you very much.
Thank you. So please sit here. So I think we had two very practical presentations. As you can hear, there is some advices, but also still a lot of questions. This is the time for you to ask questions. We will start a discussion, but please, I would encourage you to ask questions as well. So, Rodrigo, you have shown us that there is still a lot of debate and that you're designing a Delphi process, right? That is the method of choice to use when there is no clear evidence available to base guidelines on. You ask experts, and you ask enough experts. You propose statements to them, and you ask whether they are agreeing with the statement or not. And if they are not, ideally you ask them why they do not agree, because hopefully, if the agreement is not enough, usually the level is 80% of experts agree, you can maybe adjust your statement in such a way that most will agree. And you might end up, finally, in a Delphi process with some statements that there is just no agreement on, and it's clear that, that more evidence is needed. So I think there were some nice questions that I still think we can already debate, some of your questions that you discussed. So, for example, and I just would like to hear your opinion, and then we can discuss, for example, on the location of the tattoo. Pradeep has told us that it should be far enough from the lesion we are interested in, but should we do, for example, in a case of a carcinoma, and you're referring the patient to surgery, should the tattoos be placed proximal or distally of the lesions? Is there any rule for that, any logical thinking, or not? Rodrigo.
That both approaches have been proposed. It is more common to do that distally, the anal side of the.
Can I just correct the same thing? This term proximal distal is very confusing. Please get rid of this term completely when tattooing. Just go for oral side, anal side, cecal side, anal side. Even surgeons will understand that. Yeah.
No, really? Your surgeons won't?
They will. But proximal distal endoscopists get confused in colon. You don't,
yeah?
but I do.
Okay.
I'm getting old.
Sorry for you, yeah. Okay, anyways, oral, I can go with it. Oral,
yeah,
or anal.
It is important to be understandable everywhere, even for surgeons. So, anal, in the anal side of the colon, that's the most common place. I think the more important thing is to have a previous agreement between all the team in the at least local agreement. It is important to have a local protocol for that everyone being in the same page, because if not, if you do things with different protocols, surgeon and everyone will be confused. And the important thing is to have clearly located the lesion and also reported in the endoscopy report, and also photo documented ideally.
Yes, agree. You do too, Pradeep?
Yeah, absolutely. I mean, we don't see a logic in if you're sending a patient for cancer surgery, I don't see a logic in doing a tattoo on the cecal side of it. Mm-hmm. There has to be a special reason why you want to put a tattoo on the cecal side. So we always put it on the anal side, because if you put it on both sides and the surgeon only sees one of your tattoo, that causes a lot of confusion.
Yes. So I think that's absolutely important. So I think there's more logic thinking for the surgeon to do it distally, because that's going to be where he wants to probably make his decision.
Who in the room has a protocol, a local protocol in their hospital for doing tattoo?
Oh, that's interesting. Not so many. So does it mean that in all your other practices you don't tattoo, or do you do what you think is best? Don't tattoo yet? No tattoos? Who is not tattooing yet, or not at all? Okay. Okay, so most are. So that means that you do what you think is best and then describe in the report, or do you go by another guideline? No, you do what you think is best. Okay, great. Yes? Do you have a comment, please? Yes?
Hello. So some of the surgeons, they prefer to put a clip on if this is a cancer and they are going to operate the patient, to do a clip, then do PFA after the scope, so they can recognize exactly where the lesion is. Is it in the sigmoid or up in the? What do you think?
But that would mean that you would place a clip so you can see it radiologically, and you would directly do then a imaging or at surgery.
No. So as Professor Bhandari mentioned, that a patient they have done to 7 centimeter, then it migrates. Yeah. So do you think adding a clip to the site?
Adding a clip to the tattoo can help with localization.
But the clip will fall off by time. I mean, I don't know the waiting time in your situation, but in my situation, there's a big chance a clip in normal tissue and even in cancerous tissue will probably have fallen off already.
Because some of the patients, we said it is the lesion there in the sigmoid, and when they done the surgery, they found it up there in the splenic flexure.
Yeah, but that's exactly the reasoning for tattooing, right? Yeah. So that's why the surgeon needs a permanent way of looking at it. And in my opinion, but it's open for discussion, a clip is not, and a tattoo is. But yes, sometimes he might run into surprises, because we have all agreed in an MDT that this patient with let's say, a tumor in the hepatic flexure, and he is going to have a right-sided hemicolectomy, appears to have a tumor in the splenic flexure after all, and that means that once he is doing his maybe laparoscopy or opening the belly, he sees he's going to do another procedure than he was intending. So yes, if he wants to be 100% on beforehand what he's going to do, you might have to think of other ways like you propose. But I think there's many uncertainties in the clipping, because one is the location, the fact that you lose it, and two, I would say, is that the actually even not the clip placement in a radiologic examination will always mean that you know where it is in the colon, right? Because the colon might not be in the same position in every patient. So that would be my reasoning. I don't know if there's anybody who wants to comment on that.
I agree. I think it looks like you've been bitten by this problem of saying splenic fracture and turns out at hepatic flexure. It's happened to all endoscopists.
Yes.
That the cancer turns out, but trust your tattoo. That will help. Don't need additional help. The clip is a very temporary solution, will not last, so I won't worry about it.
Yeah. Yes, please. Could you speak in the microphone, please?
From a technical point of view, I think it's very important to emphasize the question of tattooing in opposite sides because of the surgical peroperatory findings of the mesenteric and antimesenteric border, more than if you tattoo distal or proximal to the lesion, as long as you have a protocol, or you clearly report on your endoscopic report where do you place the tattoo. What do you think about it?
Absolutely. But even though it is important to try to collect the small evidences we have and to try to give good advice for doing these local protocols that I think are absolutely necessary.
Very, very valid point, because endoscopists never understand which is the mesenteric border, which is the anti-mesenteric border. Mm-hmm. But if you do this by doing two opposite, diagonally opposite, you don't need to worry about mesenteric and anti-mesenteric border.
Okay, but these are the instances where we are considering, or for sure, referring the patient to surgery, right? Yeah. How about tattooing other lesions where it's not the indication, it's definite surgery? So you've shown some other indications. I think a potential cancer, right? Once you took it off and you're not sure if it's benign, you might do the same thing. You might want 2 tattoos distal, because if it turns out to be a cancer and you took it off erratically, you don't have to go back to place a tattoo, right? So, but how about benign polyps? What would be, for experts, the moment that you would decide to tattoo a benign polyp? You are an expert, so that's the situation that you are removing that polyp. Later we can discuss on whether you want a referred patient to be tattooed for the polyp, okay? So when would you decide for a benign-looking polyp it to be tattooed anyways?
Well, that's very interesting, because I have a very skewed practice where all these benign large polyps get sent to me, and all these polyps have been tattooed. I sometimes think, if there's such a large polyp, do you really need to put a tattoo for me to find that out? and wonder why you're tattooing that. So it's very difficult. I think you have to understand the endoscopist psychology. If he's thinking that I might not remove it and his patient might go for surgery, maybe there is sense in that. Otherwise, for large polyp, describe where it is, what type of polyp, and send it. You don't need to tattoo that.
I think that's absolutely...
I think that there is also, probably we need different things for different aims. It's not the same to send a patient for laparoscopic surgery, where the tattooing should be well placed, clearly placed, because it's a complete disaster if the lesion has not been. We have to do our best for identifying, for helping our colleague identifying this lesion. And another situation is when we, for example, a very difficult situation, in my opinion, the most difficult is when to suspect the polyp you have removed could be malignant, because it is another disaster. We all have deal with that, to have a small polyp that at the end was a cancer, then at the end has to be operated, then at the end nobody knows where is the lesion. So to have a high degree of suspicion for tattooing, it is important, and it's something we have to learn.
Yeah.
But on the other hand, as I said before, in the screening programs, in the feed-based screening programs, we frequently see patients with different large polyps, and if we have to tattoo all these polyps, probably the tattooing at the end is unuseful.
Yes.
So
we need
it
different
is
colors
important
of
to set
tattoos,
an
then.
adequate cutoff for tattooing. It's not easy.
Yeah. So yes, so concerning the cancers again, so I think it's clear that we tattoo a clear cancer. We tattoo, as endoscopists, lesions that we think might be cancerous because we took it off, but we are not sure, right? When we think it might be cancerous, but you're referring it to a referral center, I think we almost agree. But again, we have to do Delphi. Yeah? This is just a proposal. We might agree not to tattoo it yet, because an expert is going to have a look, and he might tattoo it. And then there's the situations that you did not expect a cancer. We call that in my center an oops cancer. You didn't expect it, you took a polyp off, and your pathologist tells you it was malignant. And then usually you're not convinced about radicality. You're going to run into a discussion with making scans of your patient and having an MDT and discussions with your patient. In my center, and this is a question to all of you, it would be usance that as soon as I get that report in with an oops cancer, I didn't expect, but it is a cancer, we go back in. So we discuss with the patient, we have a surprising finding, we have to continue working on it. The first thing I do is I plan an urgent new endoscopy to look at to find the scar. Because if the lesion was not very large, or if you took many more polyps, it might be really difficult to know afterwards which one was which. So the sooner you go in, the more chance you have, you would still be able to locate the cancer polyp taken off. Do you agree? Would that be your use as well?
Absolutely.
That's a very difficult situation, and that is the only way to manage that.
Yeah.
And
Yes,
another situation, whenever you do a piecemeal EMR of a large colonic polyp, even if it is a lateral spreading tumor, granular homogeneous, which has a low probability of advanced cancer, would you think it's more advisable to tattoo?
Yeah. That was a little bit my question before to Pradeep, but you went to the cancers referral case. But would you, I think it's a good question, would you?
Just describe again, sorry, my
A granular, non-suspicious LST.
that I've removed.
Yes, would you tattoo?
Yeah. I think that we will always tattoo, because there's still about 14% recurrence rate and about 7 to 8% cancer, covert cancer, oops cancer rate in these, even in expert hands. We're not perfect. So for those cases, we will place a tattoo after resection.
And you tattoo as well?
Me too.
Yeah.
Yep.
I probably would not.
Probably it's not necessary to do anything circumferential, nothing like that. Probably with one tattoo
Single tattoo.
is enough. But you don't?
No, I would not. If all my resection goes very smoothly, I have no suspicion of submucosal ingrowth, and I think it's a benign lesion. yes, I know I can still be surprised by pathology, but I would take that risk because it will be easy to go back in again. And the second thing is that I can go back in, but the scar is going to be big enough to find it back for any local recurrence. So, I mean, I think the debate is more about maybe the polyps 10, 15, if you have to take it in 2 pieces and you're not sure about radicality, I think those we should tattoo because the lesions the scar will not be very big. We know, however, so I have to take into account, it's balanced thinking. If I would have any suspicion for invasive growth, I would. And we know from Michael Burke's group's work that it's not only the pit pattern that will help us enough, although we are getting more and more experience in using advanced imaging techniques to characterize lesions. We also know that still we don't always see the cancer, especially as he's described, and Burgess has done that in Gastroenterology 2017, that also the morphology of the lesion also predicts a certain covert cancer risk, which means you're not going to be able to see it on the outside, but for example, a laterally spreading lesion that is granular with one big nodule, or the non-granular ones, they have a higher risk. So that could be reasons for me to still tattoo. But I take this into account when deciding. But doing all tattoos, like you say, you might end up with 3 or 4 tattoos in the patient, and I'm going to request the firm to make me several different colors, because I don't know which one was which anymore, and I will never be able to explain my surgeon.
The question was precisely because of the low risk, granular homogeneous.
Yes. Yes. So again, the question was especially for the low risk. It would be my opinion not to, but I think those two are in doubt. So. No, but that's nice, and that's why we're going to do that Delphi process exactly for that reason. And it might that we don't end up with a final agreement on that. We will find out.
Evelien, if you have to follow up a piecemeal resected large lesion, put 25 millimeters, 30 millimeters, you in the descendant column, you put the tattoo or not?
I think that's about on the edge. I probably would not, but I think that could be a nice research project, because it would mean how often are you sure you find the scar back when going back. I think that's the question, right? How often is it difficult to find your resection scar after a large polypectomy, a smaller polypectomy, an even smaller polypectomy? And I think what also has to be taken into account is the number of polypectomies you've done in that patient. If you've done more than one, there might be other reasons to do it. But I think no agreement, and I think the most important message for me is that always think about placing a tattoo and rationale, or how do you say, logical thinking for doing, or maybe sometimes refraining. Yes. Any other questions from the audience? Yes, please, sure. Could you go up to the microphone?
Your third option that you mentioned is to inject saline and then take the needle out and inject the D. Is it not possible? Is it possible to the second injection will be to the peritoneum?
If you already have a raised bleb, then highly unlikely, unless you are really careless and push it too deep. Because if you have a nice mucosal bleb of saline, and you go back within 3-4 minutes, the bleb will stay there. So the risk is low, but everything is possible. Yeah. But we are just minimizing the risk.
Yeah, so I agree. And I think it's interesting that what we don't know is if you place the bleb with saline, there's the same risk, right, that you perforate into the peritoneum, but it's saline, so it doesn't matter, right? So that's why we do the saline bleb. But what happens because you made a leak already? So if you then inject tattoo, I just don't know the answer. Apparently not, because I don't get any complaints from my surgeon ever since we do this technique. Yeah. So apparently it's not a problem. Yeah, but I think theoretically I could understand it would still leak.
But if you just push the needle through the muscle, as soon as the needle comes back in, generally the muscle fibers, because you're just splitting the fibers, and it will come back together, seal. That's why we don't hear it.
Yeah. Yeah, maybe. So that's very practical question.
Yeah.
Very nice. So yeah, that's. I think this is good reasons for taking a safe method. I mean, we've all. I think people experience with tattooing. I've had severe complaints from my surgeon from a totally black peritoneum, and it's not only the fact that he can't see anymore where the original tattoo was placed, it's also that everything is fibrosed, and he's going to have a surgery of an hour more to try to nicely dissect all the resection planes. So I think placing the tattoo should be really done in a correct and very secure way. So any last comments, maybe from my of the two speakers? Anybody from the audience with any last comments or questions on this topic? No, so let me finalize by thanking my two speakers of today, Rodrigo Jover and Pradeep Bhandari, for their excellent presentations. I think we had an interesting discussion. I hope you've learned more about the use of placement of tattoos and how to perform best practice in that. Although there are still, again, areas of uncertainties. And please remember that if you're interested to see this symposium back or to advise your colleagues, look at the ESGE learning space where you can find the recordings of this meeting. So thank you very much for your presence. We're really delighted to have you all, and have a good rest of the symposium.